All right, good morning. I am going to kick this off right on time because we have such an exciting agenda. And for all of you who's on Zoom, we're beyond thrilled to be here live, and the excitement is palpable, partly because we're so happy to be back together. Yay! And our chief residents are here, and we just have the most extraordinary speaker to kick us off. So I'm going to try to move through some quick announcements. First and foremost, I want to thank our Grand Rounds Committee, and I want to thank Alan Schroeder, who has chaired this committee so beautifully for so long, and through the pandemic, this incredible series of speakers we've had. So we'll talk about that in just a minute. As always, everybody knows you can get CME credit, but you can now get MOC Part 2 credit as well. Information is on this slide, and we'll put it in the chat and make that available to people who are just settling in. And then so speaking about the Grand Rounds Committee, so Alan has chaired this. Olia Kors is now moving into that role. And I just want to thank our members, Deb Babcock, who's a community pediatrician, Lisa Chamberlain, Baraka Floyd, Chuck Gawad, Lauren Kushner, Ryan Lyon, Steve Roth, Stephanie Squires, and Yo-Yo Zhang. Incredible committee. We are in communication almost every day. And here is the fruits of their labor. This is quite an extraordinary lineup for our next few Grand Rounds. I want to point out Nancy Spector, who's executive director of the Executive Leadership in Academic Medicine, the ELAM program, which is just this extraordinary program for women leaders. The number of women leaders that I've met who said that they were in that program. She's also been a leader of the IPASS study group, the research group that focuses on patient safety and communication, as well as education, innovation and education. We're excited she's coming. John Paul Sanchez is the principal investigator of the Building the Next Generation of Academic Physician Initiative, which is nationally recognized for developing the concept of pre-faculty development with many dozens academic health centers to educate trainees, faculty, and senior administration on how to develop the upstream pipeline of diverse medical trainees. And then so fortunate to have Lisa Meeks, who is an expert in disabilities and medical education and really informing policy and best practice in the area of disability inclusion for medical education. So looking forward to that. Here is the CME and MOC information. And now my great pleasure to tell you about Dr. Norm Kretchmer. This is the way we kick off Grand Rounds each year in the Norm Kretchmer Endowed Professorship. This is the 25th annual Endowed Lectureship. Dr. Phil Sunshine has shepherded this program so beautifully for many years. And this is the first year that I'm going to get up and try to describe Dr. Kretchmer's many accomplishments. But we were so lucky that Dr. Sunshine joined us at dinner last night when Dr. Glader and the people who really knew Dr. Kretchmer, and we learned a lot more last night. So this was established in 1997 by colleagues, friends, and family of Dr. Kretchmer in recognition of his lifetime of research and service in pediatric medicine. He was a really distinguished nutritional biochemist and pediatrician. In addition to his MD, he had a PhD in physiologic chemistry. And he's just, in his very early years, just gained such wide respect for his expertise and discovery in developmental enzymology and infant and childhood nutrition. In 1959, he was appointed chair of the Department of Pediatrics at Stanford, where the department included 4 faculty. And he just built this environment that enabled faculty to really engage in interdisciplinary research. We are now 400 faculty. Another major achievement at Stanford was to guide the foundation, really the conception and the foundation of the human biology program. The HumBio major was the most popular major on the Stanford campus for decades, until now computer science, I think, is right there. But Paul Fisher led HumBio for a very long time, and it really was such a bold and innovative program. The whole premise that healthcare, environmental, and political problems should be addressed from a biological and social science perspective. Then in 1974, he was selected to be director of the National Institute of Child Health and Human Development in Bethesda, NICHD, which is really the Institute for Maternal and Child Health, and was in that position for 7 years, where he maintained the Institute's important reputation as the only one of the National Institutes of Health who didn't have a specific disease orientation, but a very broad mandate covering children's health. So I think just an extraordinary set of accomplishments, and just the perfect person for today's speaker, to honor today's speaker. So my incredible privilege and honor to introduce you to Michael DeBaun. Michael is a Stanford Medicine graduate He and I overlapped for just a couple years, and most recently in 2019, he's the recipient of the Stanford's J.E. Wallace Sterling Lifetime Achievement Award in Medicine. He has many, many, many other awards, but the ones that are near and dear to our heart is the Maureen Andrew Mentor Award from the Society of Pediatric Research, and he has the American Society of Hematology Mentor of the Year Award. He's currently the J.C. Peterson Endowed Chair in Pediatrics, and among his many accomplishments is the founder and director of the Vanderbilt-Meharry Center of Excellence in Sickle Cell Disease. Just an extraordinary, extraordinary research career. I can't even begin to describe the arc of his research, but just most recently, some of his active grants are the management of severe acute malnutrition in children with sickle cell disease greater than 5 years of age living in northern Nigeria, looking at clinical and genetic risk factors associated with adverse long-term health outcomes after curative therapies in individuals with sickle cell disease, prevalence of neurological morbidity in young adults with sickle cell anemia in low resource settings. I could go on, but last night's dinner, I think, was a real reflection of the interdisciplinary nature of his work, because we had folks that are passionate about global health, hematology, mentoring, so many different areas. So with that, Dr. DeBaun, welcome, and delighted to have you here.
This is a homecoming for me in many ways. I, in part, learned what a complete physician was when I did my pediatric rotation and had Burke later as my attending. And that memory of reading the history before you go in, taking the history, listening to the patient, performing the exam, having a differential diagnosis, not knowing exactly what to do, going back to the patient to get a better history, and then reading was really an imprint on what I thought a complete physician should be, and actually was a major determinant of why I wanted to go into pediatric hematology oncology, because I didn't see that full picture in any of the subspecialties that I had rotated through in medical school or in my residency. The other part about this is I grew up here. I went to undergrad at Howard, and I was in a cocoon, if you will, historical Black college. Basically was in a very supportive environment, and coming to Stanford was an awakening. And I came here with an attitude that I could change the world, and I learned quickly that I had to change my attitude. So I'm going to show you this journey that I was on that actually started here at Stanford. So this is definition of activism. And then this is my life story, truly. Medical school, junior faculty, I'll give you a couple of slides, mid-level faculty, midlife crisis, which I did have. And then winter is coming for me in 2022. So the slides can change, but the definition does not. And over the last 10 years, I've actually given this talk several times. So the definition of activism is consists of internal intentional action to bring about change in one or more of the following domains. This is from Wikipedia in 2010 when I first gave this talk: environmental, social, political, and economic. However, this wasn't the definition in my home. The definition was really, according to my parents, not accepting status quo when you know you should and could be better. So I was a third-year medical student at Stanford, and I was on the admissions committee. And I had a student that I was looking for students from Howard. You had that chance to kind of recruit from your own tribe, if you will. And since I was from Howard, I was looking for a student who I thought could thrive here. And this young man applied here. He got his ride to Vanderbilt, paid for by the admissions committee. But he didn't get into medical school here. And the reason was that he lacked ambition and desire to travel abroad and learn a foreign language. And so he was rejected. So what did I know that the person who interviewed him did not know? So my wife and I picked him up in Oakland at 3 o'clock in the morning. He took the red eye to get here. His first plane ride ever was from DC to Oakland. He had no pre-professional advice at all to guide him to put his application together. I know that because I was in the same undergraduate school 3 years earlier, and I know I didn't receive any, and we both commented on the lack of advice on how to get into medical school. He was the first one to finish high school in his family, and he worked full time to pay for college while being 100% independent since the age of 18. So what did I do? I lobbied hard, real hard. I went to the head of admissions, Dr. Maffley, and I said, how can this be? How can someone be rejected because they didn't want to go to Europe to learn how to speak Spanish, which was the comment in his application, rejection. And Dr. Maffley is a very warm, affable man. And he said, Mike, there's nothing I can do for you. I said, there has to be somebody. And he said, okay, you can go to the head of the faculty senate. So I really didn't know any boundaries. I literally went to the head of the faculty senate, and I burned a lot of ATP because it wasn't a direct road to get there, right? You don't really know who is the head of the faculty senate, how important is he in the medical center. You're a third-year medical student. And I was in his office, and I basically said at the end of the conversation, look, if he's rejected, then your decision to admit me to Stanford was a mistake. And the end result, he was admitted to the medical school here. He became an outstanding medical student. He was one of 2 students nationally to receive a neurosurgery pre-doctoral award. He had multiple manuscripts here as a Stanford student, which is not that unusual for the Stanford crowd. If you give this talk elsewhere, it's like, really? He had multiple first author manuscripts, but actually he did. And then he matched as his #1 program for neurosurgery. So I have gone through my early career with similar challenges of pushing up against the system as an I. And eventually I made a decision to switch from an I to a we to try to be more effective and have a bigger impact on what I believed in. So I'm gonna skip all my training as a resident at WashU, chief resident, HEMONC fellow, US Public Health Service fellow, and go back to when I came to WashU in '96. So I was learning the status quo as an assistant professor. I was the clinical director of our division of hematology and oncology, which was quite active in both the heme and the onc. So in 1996, the camp, and I'm sure it's probably the same way here, camps for children with cancer is a rite of passage. And despite that, there were no camps for children with sickle cell disease. So literally in the same clinic, you would have children talking about taking a trip with other families, and you'd have a child with sickle cell disease not understanding really what were they talking about. It wasn't just the trip, even celebration of birthdays. If you had a birthday and you had a child with cancer, you get all these wonderful presents. Same day, child with sickle cell disease, we get no presents in this same clinic. So I said, well, we can do better than this. And really, I had no resources. This was not a setting where the hospital supported the initiative for children with sickle cell disease. But I was from St. Louis. I grew up there. I had deep roots within the community, not financial roots, but roots of where things were done for children who were underserved. And so we identified a camp that was available for children who lived in the city. And the first week of camp was open. And so for 8 years, we basically, with a hope and a prayer, was able to put this camp on. I did fundraising outside of the development office because they weren't interested in it. I had fashion shows, gala, even had several funk bands play for us to raise money. And all of this was really done out of a passion of love as a team when we formed the sickle cell team. The sickle cell team was actually funded extramurally. It wasn't funded by the hospital. It was not funded by the division nor the department. And then in 2009, it was recognized by some of the nursing leadership that the hospital was supporting other camps for children and not supporting the sickle cell camp. And at that point, leadership decided that out of parity, they would now support the sickle cell camp at St. Louis Children's Hospital for children with sickle cell disease. And so that camp has been ongoing now since 2010 without this concept of going out to raise money. So the other challenge I had as an assistant associate professor was there was no social worker for 400 children with sickle cell disease, despite the fact that in our division, we had a social worker dedicated to brain tumors. We had a social worker dedicated to children who were receiving bone marrow transplant. We had a social worker dedicated for our children with cancer. And we didn't have a single social worker for the 360 children. So I hit pause. You just let that sink in for a second. Now you could go to the administration and say, hey, fix this problem. This is, so you could use whatever language you want. But at the end of the day, the services were not available for the children in this space. And just knowing the system that I had grown up in and having that experience that I had as a medical student here and these other battles that I had dealt with, I elected to take advantage of this education I received at Stanford and Hopkins and other places, and went ahead and wrote a grant. And I wrote a grant and I labeled the title of the person to come in to be hired was a school liaison. Now, nobody knew what a school liaison was but me. And I was able to go out and find a social worker to be hired on our team. And this was important because this was a social worker who actually changed the course of social work in our department, or actually the Children's Hospital. So what did she do? First of all, she had a master's of medical social work. She established a different model of social work care. It was anticipatory as opposed to reactionary. So she was integrated into our healthcare team, met with our patients on a routine basis. And in fact, she became the camp director the day she was hired. Now that wasn't in her job description, but it was just us trying to do what we could to improve the care for our children. She intended the individual IEP, or individual educational plans, IEP plans for the pediatricians. You know exactly what that is. It's a hallmark of our program is to focus on the educational attainment of our children with sickle cell disease. We made home visits to families, particularly the families that visited the hospital quite a bit, to really understand what their social situation was in the home and what the dynamics were. She also, of course, had to publish because she was part of our team. One of her first manuscripts was the inadequate recognition of educational resources required for high-risk students with sickle cell disease. And also, we created this multidisciplinary team to improve educational attainment in children with sickle cell disease. And Allison King was a resident fellow at that time at WashU. Also used this as an opportunity. I was approached by the premier legal firm, biggest legal firm in the state of Missouri, Brian Cave, and they asked me how could they help. And I said, well, look, I've been pushing this agenda to get IEPs for our children with strokes for quite a while now, and there's been an absence of the school districts to provide the resources for our children that I know they need. Let me give you just one example. I had a child who had a stroke, had a vocabulary of 3 words, and yet when his IEP came in, there was no speech therapy. So, because I asked for the IEP report to come in because I wanted to see exactly what the resources were that were being delivered to our children who needed them. And so after a series of events like this, we got Brian Cave involved, and they were so trusting, they gave us their stationery. And so what used to take months to no response from the school district, usually we had a response within 5 working days of the request for an IEP. So the permanent results of this effort is now, if you go to St. Louis Children's Hospital, there's a social worker there, and everybody thinks there's always been a social worker there, but no, there wasn't. And so even today, for the fellows or residents who rotate through there, they will have a social worker. So to turn your attention to something that happened to me when I was a fellow, again, paying attention to the history. In this case, the history was given by a teacher, and the teacher had a student in her classroom, and it's the teacher peppered me with the following questions: what is wrong with this child? The student's named Michelle. Why did this occur? And what can you do to treat Michelle? And these have really been the cornerstones of my work since 1991, focused on silent cerebral infarction, avert strokes in children with sickle cell anemia. And I will only give you a glimpse of what I've done, only because it's a talk in and of itself. So Michelle actually had what's referred to as a silent cerebral infarct. And we set up a multi-center randomized controlled trial to test the following primary hypothesis. In children with pre-existing silent strokes, blood transfusion when compared to observation results in a decrease in the incidence rate of silent cerebral infarcts or strokes. It was an international trial, including folks in Canada, UK, and France. We had a statistical and imaging core at WashU, and the trial took 10 years to complete. And most importantly for me, in addition to the care for the children with sickle cell disease, we also use this as a backbone specifically for mentees in my lab and others' lab to get K23 awards. So 3 individuals got K23s on the backbone of this trial, and 2 individuals received Doris Duke Faculty Development Awards. So here's the result of 10 years worth of work on one slide. Our conclusion was that regular blood transfusion when compared to observation decreased the relative risk of infarct recurrence by 56%. But I want to give you a snapshot of the children and the families that participated in this trial. Because I was hypersensitive to the issues of social determinants of disease, we actually took a fair amount of information about the social determinants in our patient population at the start of the trial. What I want to highlight is that the yearly income per capita was $8,500. Now, in this population, this is what we asked them to do. And 86% of the patients finished the trial. We asked them specifically to have monthly transfusions for 3 years, 90 participants. We asked for 3 MRIs of the head. They had to be non-sedated because of safety. We had 4 neurology evaluations by pediatric neurologists. We had 3 cognitive tests to be performed in this patient population. We had 2 quality of life assessments. And with all of that, we had 86% of the children finish this trial. So in addition to this, 9% had completed partial exit requirements, and only 5% did not exit the trial with the data we needed for evaluation. So every time I hear the rhetoric about African Americans unwilling to participate in clinical trials, I have to take a pause and think about, well, what did you do to include them in the process? And we were very, very deliberate about the strategy that we took, extremely deliberate. And so one aspect of being a pediatric hematologist, particularly a pediatric hematologist that takes care of children with sickle cell disease, is that most of the families know that we're going to take care of them whether or not they participate in the trial. Our first introduction to the child is not when we have a study, do you want to sign up? It's how you doing today? And so this paradigm shift, I think, is critical when you start to hear the rhetoric around African Americans not willing to participate in trials. No, they will participate in trials. Actually, I think they'll participate at a higher rate when they know that you're willing to provide medical care for them, regardless of the outcome. And there's also the rhetoric around you have to be Black to enroll patients with sickle cell disease in trials. That's just baloney. The majority of the providers were white. Okay, so there's a lot of discussion around these areas when in fact the data does not reveal this, when you have the paradigm of the patient care comes before the research care. All right, so now I'm older, 2007, 2010. I got the accolades that you're supposed to get when you're in academic medicine as a professor of pediatrics, biostats, neurology, endowed chair. But I was increasingly agitated with the status quo. And then essentially I had a midlife crisis when I was in 2010. I took a sabbatical. I was at the CDC for a year, and I had a chance to kind of reinvent myself, similar to what happened when I left Howard and came to Stanford. And I had a summer to just really think about what I wanted to do with my life. And so there were some critical questions that I wanted to address. Why is there no effort to decrease the rate of mortality and morbidity where 70% of the children with sickle cell disease are born in the world? Why was there no NIH-funded study in Africa? And then why are we not doing better with curative therapy in children and adults with sickle cell disease? So I want to tell you a brief story. It could be a whole grand round in and of itself. In the United States, the pregnancy-related mortality rate is 26 deaths per 100,000 live births. Now this has gotten the US folks up in arms because when you look at our mortality rate, maternal mortality rate compared to the rest of the high-income countries, you can see that our rate is significantly higher, particularly for the countries in Northern Europe. want to share with you the data from Ghana for women with sickle cell disease. It's 10,000 per 100,000. Like, I still don't understand why this is not out. Like, why isn't anybody like jumping up and down? Like, how is this possible? And so by a series of events and clinical studies, listening to the patients again, taking the histories, looking at the autopsy results and why, or the postmortem evaluations of why women died, we were able to come up with a strategy to decrease the maternal mortality. And so in a before and after study, we demonstrated that we can decrease the maternal mortality in women with sickle cell disease at the flagship hospital in Ghana, Korle-Bu Teaching Hospital, by 89%. So here's the before event rate was roughly 10,000 deaths per 100,000 live births, and we dropped it down to approximately 1.1 thousand per 100,000 live births when compared to the general population in Korle-Bu Teaching Hospital, which is 548. I was very excited about these results. I mean, I said, gosh, I don't know if I'll ever do anything to ever have a bigger impact than this. And, I submitted it to our premier flagship journal in America for hematologists, Blood, and it got rejected. I was like totally down about that. Then I got a phone call from New York Times reporter. And I said, hey, I'm so glad you called. Let me tell you the story. And he says, yeah, I know the story. I want to report it. And I said, great. I said, I got rejected by Blood. He says, oh, don't worry about it. Our readership is 10 million a day. So this was a multidisciplinary team, okay? And this was low tech. We found out that the major reasons that the women were dying was because of acute chest syndrome. So we used old-fashioned strategies that you use when you are taking care of sick patients and you don't have people well informed about how to take care of sick patients. So we used the Tulgawanda's checklist manifesto for how you actually identify an individual who has acute chest syndrome, how you prevent acute chest syndrome, and once they have it, what should be the management associated with acute chest syndrome. We made it a multidisciplinary team, recruited a pulmonologist, who was also an intensivist onto the team, had a hematologist come onto the team, provided them with pulse oximetries, and then made sure that the adult hematologists were literally integrated into the care of the women who were sick on the floor. So this was the we approach here, members of the team. So in 2021, as a follow-up, 6 years after we had reported this work, we demonstrated that even after we had this protocol, we still had kept the death rate for pregnant women down to 1,000 per 100,000 live births. And we're now expanding this strategy to additional hospitals in Ghana, 2 additional hospitals in Ghana. And here are members of the team, and I'd be remiss if I didn't point out the gentleman right to my, right here, Sam. He was a OBGYN resident who just literally had finished his residency, and he was the one that set up the clinic for pregnant women with sickle cell disease. It's really his initiative. And he set the clinic up, and the death rate was still at 10,000 per 100,000. And so he approached me when I was in Ghana and asked for some support, and I said, absolutely. And then the other people on the team, you can see Adetola Kasim is with the guy with the glasses right there. He's the adult hematologist at Vanderbilt, and we're basically have the same circulatory system. We work together closely. We meet 3 to 4 times a week. All of our grants are jointly submitted together. And he's not only an adult hematologist, but a transplant physician, which will be germane as well. And the woman out in the left up there started off as a med tech when I was at WashU, and was about as rough around the edges as you could get, with a lot of encouragement and support and pushing. She got her RN degree. She became a SOCA certified and really is considered one of the top research coordinators in sickle cell disease in the country, and is acknowledged that she actually does the work for the trials on the adult side. Well, I'll stop. I could keep going about everybody else, but I'll stop there. So I want to turn your attention to the adults for a second. As I mentioned, the adults and the children don't have a high uptake in curative therapy. There's a lot of different reasons. For children, the overall survival in 2022 is 99% to the 18th birthday. So there's always a little bit of a pause about, should I offer curative therapy for a child who has a 99% chance of hitting their 18th birthday. Not the case for adults. For adults, the median survival is 48 years. This is a study that was done with 2 centers that have an outstanding adult sickle cell program. This was UNC with Kenataga and Adetola Kassim at our center. And what we showed when we combined the data from our 2 groups was, in fact, that the median survival had not changed in 25 years. So why aren't more adults with sickle cell disease transplanted? There are 2 major barriers. So 2 major challenges. The first is that there's a small donor pool, and this has been a major limitation for over 30 years when transplant was being offered to children and adults. And because the adults have this comorbidity associated with sickle cell disease, comorbidities of heart, lung, and kidney disease, they typically cannot sustain myeloablative chemotherapy. And as a result, adults typically cannot receive the match-related donor transplant protocol that children are able to receive. And this is one of the reasons that most of the individuals cured with sickle cell disease up until recently has been children who were less than 16. The mortality typically goes up when you're 18 and above. And so this has been a major hard stop for most programs to perform myeloablative chemotherapy transplant programs for adults with sickle cell disease. So fast forward to 2012, the Hopkins team had recognized this strategy. This is for folks who are not in transplant physicians. This might be a little deeper than you may want to learn on a Friday morning, but I'll try to break it down. So the Hopkins team recognized that these were the 2 major barriers, elected to have a strategy referred to as haploidentical BMT with post-transplant cyclophosphamide. And what's important about this protocol is that you only need an HLA half match. So an HLA half match could be a sibling, it could be a parent, the obligatory mother, typically the father as well. And for the adults, it could actually be a son or a daughter. So this expanded the donor pool dramatically. And in fact, about 90% of the adults who want a transplant will have a haploidentical transplant donor. And this was actually a very important study. Why was I skeptical about the findings despite being published in Blood? First of all, this was a single center study, prospective trial. It's actually very uncommon for single center trials to change clinical care in a rare disease. And so I had a very healthy skepticism that maybe we should try to replicate this or expand. It's not generalizable to other sites, again, because it was single center in a rare disease. And it had systematic, and there's clear evidence when you look at the epidemiology literature that a single center trial typically overestimates the treatment effect when compared to a multi-center trials. And then there was a strong disagreement in the community. Among the hematologists, we were like, hey, here's a therapy that has a chance to cure. If you fail, you go back to the disease with a low level of mortality. So we were pretty excited about that. But when you go to talk to the oncologists, particularly the transplant docs, it's like, but you had a 40% rate of graft failure. That is just too high. And so there's really literally a tug of war between these 2 communities, like you've never seen before, where the oncologists will literally try to increase the treatment with more chemotherapy to improve the engraftment, but clearly this will occur with a higher rate of death. And so this is a real balancing act between the 2 communities, and we've tried to hit the right tipping point to support us in this space. So we actually ended up trying to go after funding, and we put together this Vanderbilt Global Haploidentical Transplant Protocol. Dr. Brodsky, who is the head of hematology at the time and the senior author of this manuscript, and I submitted an application to Doris Duke Foundation in 2013. This was not funded. We set up a mock study section to see, well, if we're not funded, what could we do better? And this was chaired by John DiPersio, head of oncology at WashU, and Mark Walters. And at the end of the mock study section, they said, you're not quite ready for prime time, so come back to us. We later went on and started this learning collaborative. And we submitted our application to the NIH BMT-CTN twice in 2013 and 2015 and 2016. This is the cooperative group for transplant for across the globe. It's the most prominent transplant consortium in the world. And we didn't get funding. Not to be scared by a no, we came back again and ultimately got funded in 2017. Myself, Ayatollah Kassim, Brodsky, and the original person who told us we were not quite ready for prime time, Mark Walters in UCSF Oakland. So we have started this trial. We'll finish the results. Will come together by 2024. And it's actually quite exciting. I want to at least highlight the results of the Vanderbilt Learning Collaborative. Here we are in London with the collaborative teams of folks from Paris and London in that international city of Nashville. And you can see Ayatollah Kassim and Rob Brodsky and Francois Bernardine and other folks who are focused on sickle cell disease and cure. Our first publication from the Learning Collaborative was published in this journal, as you see here. The title was Haploidentical Bone Marrow Transplant with Post-Transplant Cyclophosphamide plus Thiotapa Improves Donor Engraftment in Patients with Sickle Cell Anemia. The Thiotapa was our addition to the Hopkins protocol. And the early results revealed that we had 100% survival and 33% developed acute graft versus host disease. All were treated with immunosuppression, and 93% of the patients developed durable donor graft engraftment. Fast forward to 2022, and we just submitted our abstract for this group to ASH. This is the crew right here in the picture. We have enrolled 83 participants across 7 sites, which includes individuals from Brazil, Germany, Netherlands, the UK, the United States. Entry criteria is site-specific, so we didn't burden everybody to say you had to think exactly like we think at Vanderbilt, but it's up to your local decision-making as to who to enroll. All participants had to follow the backbone of the trial. Supportive care measures vary significantly by site. This group actually meets every other week. We used to meet weekly because for the transplant docs out there, there's a strong belief system. And it's almost like, no offense to the neonatologists, it's almost like practicing neonatology early, where there's a lot of different practice variation in how you manage the patients. And so we were able to try to harmonize the practice approach across the globe. Our results are actually quite interesting. It turns out there were 8 graft failures. All the graft failures occurred in children. Nobody would have anticipated that. In addition, the adults were all alive up to 2 years after transplant. Again, it's really not the anticipated result that the adults would do better than the children. And so this is resulting in us having to reorganize our thoughts about how to better change the protocol for the children. And we believe we'll keep this same course with the adults with sickle cell disease, given the results to date. So in 2020, there was a fair amount of unrest across the country. And I think all of us had to take a gut check as to how will you be held accountable for improving the injustice in America. So I'm going to share with you some of the strategies that I have introduced using the we approach as opposed to the I approach. Prior to the 2020, after I left on WashU and came to Vanderbilt, it was clear that some of the skill sets that I had learned at WashU and had observed, basically passive observation. It wasn't like somebody put me in their arms and said, hey, come on in, let me show you how to do this. This is how you write a grant. Let me review it after your first draft, your second draft, your third draft, your fourth draft, your fifth draft, your sixth draft. That didn't happen. But I did see how people were being mentored to do that. And so obviously for the folks on my team at WashU, I was able to support that strategy. But when I came to Vanderbilt, there was no such culture for the Black faculty who wanted to pursue science. So I started a breakfast club with another senior faculty gentleman who was a member of the National Academy of Medicine. And we met with 2 Black faculty and 1 Hispanic mid-level faculty from 2012 to 2014, had honest conversations about their productivity and about the work environment that they were in. And so the results 3 years prior and 3 years after starting this breakfast club is as follows. The accepted manuscripts increased from 22 to 52, which was 130%. The funding increased from 1.34 million to 2.0 million, 100%. All 3 faculty achieved advancement in career prominent academic leadership roles. One is now the one that they put out the pastor at Vanderbilt is now the chair of OBGYN at WashU with her own R01 funding that's independent. Another is chief of pediatric ID at the University of Buffalo, and Wonder is head of the sarcoidosis center and is considered international expert in sarcoidosis at Vanderbilt. So in the summer of 2020, again, to address this issue of what should we do, these are the medical students that are in the Vanderbilt-Meharry scholarship program. And it's intended a program that I was able to start as at Vanderbilt and Department of Pediatrics to introduce medical students at Meharry to research and medical school and physician leadership. And so these are the students here. And I must say that during that summer, they were challenged. In fact, we had questions specifically about how do we practice medicine in another country? Because we're not sure we want to stay here in the United States, given the level of turmoil. There's a lot of soul-searching conversation, including conversations about what I was going to do in this situation and why wasn't I out marching? And so in the end, I had to come to grips with what was I going to do? And so what I ended up deciding to do was write another grant. And so I wrote a grant to the Burroughs Wellcome Foundation to expand this program from pediatrics to include the School of Medicine. The Department of Medicine signed off, and for the first time, the Department of Pediatrics signed off as well. So they are now cost sharing my salary, which doesn't mean much to probably anybody in here but the department chair. And that meant that I was being paid to lead the program that I had previously been leading for the last 7 years. But in this particular case, it was on the books. And so was the case for the Department of Medicine. What's really interesting was Dr. Drake, the person who's in charge of the sarcoidosis center, had never even heard of cost sharing. And she said, wait a minute, I don't quite get this. You mean they're going to pay 10% of my salary for mentoring folks, and the department's going to pay the full salary? It's not going to be the salary that is, capped at $200,000 a year? And I said, yes, that's the story. That's actually what's going on. She probably called me about 3 times about that exact point, just to describe how challenging it is when you're trying to develop programs to mentor others, and there's really no resources. And yet, in the ecosystem of academic centers, as a vice chair, I can tell you, I have seen people get cost shared for activities far less than what I'm just describing. And so one of the advantages of this program was that in addition to the 8-week summer program for the medical students after they finish the first year, we got a sign-off from the president of Meharry Medical School, as well as sign-off specifically from Burroughs Wellcome that we can have a 1-year pull-out program very similar to the medical scholars program at WashU and Vanderbilt and Stanford, where you can actually do research for a year. And so I'm fast forwarding to Puerto Rico, 2022. I went out to visit a colleague of mine who's head of the Department of Pediatrics at the University of Puerto Rico. The purpose of the visit was to expand this program that we now have set up with Meharry medical students to include medical students at the University of Puerto Rico. They'll come to Vanderbilt over the summer. I will pay them a nice stipend, and they'll be engaged in activities to improve their leadership skills and their academic skills. I also went there to promote the membership of their faculty in the American Pediatric Society. As you know, Mary is past president, and we feel that this is an important program for all pediatric faculty to be engaged in. And so I was an ambassador for the program for that. We have expanded our collaboration for sickle cell research there. And then as a hint to myself that I can't keep adding on mentees to my mentor tree, that I have to kind of trade off. And so I identified a young lady who's a pediatric resident who's very interested in sickle cell disease. And she's going to actually work with Dr. King, who's a professor of pediatrics at WashU and an expert in implementation science. And I will be the co-mentor for her. And then I'd be remiss if I didn't shout out Mauricio, who's sitting in the back. He's the medical student from Meharry who's doing the 1-year pull-out program here at Stanford and working with Michael Longacre. Really a credit to his go-get-itness to find me and have a wonderful written proposal that was easy to say, yes, you deserve the opportunity to work at, with one of the best in the country, if not the world. So I just want to shortly touch on some strategies for political activism that have happened over my career. I was able to effectively lobby the state legislators to increase the funding for care of individuals with sickle cell disease in Missouri to 300%. That was in 1999. I was the primary physician author for the Sickle Cell Disease Treatment Act signed by President Bush in 2004. And then I'll talk a little bit about this at 12 o'clock with the residents, but given the first and second bullet, I actually went back when I started my program to prevent strokes in Nigeria to meet with the local officials early in the process of getting the R01 funding to make sure that the results that we had were going to be sustainable after the funding was gone. And I'll tell you that story this afternoon. But the bottom line is now 3 states with about 40,000 children with sickle cell disease, which is more than the total number of children with sickle cell disease in the United States. So 3 northern Nigerian states have been providing free hydroxyurea for children with sickle cell disease who are at risk for stroke since 2019. So in terms of social activism, as Mary mentioned, I'm big on mentoring, and I have focused on making sure that the people who come in my lab are serious about having an impact on the lives of children and adults with sickle cell disease. So I have former mentees who have changed the landscape of sickle cell disease, not only in St. Louis, but Milwaukee, San Antonio, Manhattan, Mount Sinai, specifically Jeff Glassberg runs the sickle cell program. He's a medical student who took a year out of medical school to work in our lab and is now associate professor and just got his second R1, Accra, Ghana, and then 3 cities in Nigeria. And what you see here is Josh. He's an adult hematologist. He works in Milwaukee. There was no adult program in Milwaukee when he showed up there over a decade ago. And this was the headline for what Josh did in the Milwaukee newspaper. He decreased inpatient admission by 50%, decreased emergency department visits by 50%, and decreased readmission rates within 30 days by 30%. So I have to tell you another story about my ambition when I was a resident. I went to a counselor, and you know how you're obligated to make sure everybody looks over your shoulder. It's so different, you know, because when you were in Stanford as a medical student, nobody was looking over your shoulder. It was like, you know, do your thing and let's see what happens. And but you know, now everybody wants to, you know, make sure you get that feedback, and you know, so I went to this senior guy and I told him what I wanted to do, and he's like, "Why do you want to be a sickle cell doc? There's no research in this area and no opportunity for research." That was my counseling session in 1990. So my economic activism, I do believe there is economic activism, includes my NIH funding as the PI. I've been awarded over $40 million. I've sponsored 5 K23s, all focused on sickle cell disease, over 2.5 million. I have 1 Doris Duke Faculty Development Awardee in my lab, which is $750,000. I had 7 medical students from Doris Duke or the CTSA funding, which is $250,000. I've had 2 medical students with sickle cell disease in my lab, which is priceless. And I had 1 former patient and mentee who is now in her 3rd year as a hematology fellow focused on sickle cell disease, with sickle cell disease herself. And I'm speechless about her journey. So in follow-up, activism consists of intentional action to bring about the change in 1 or more of the following domains: environmental, social, political, economic. And I'm still unwilling to accept this status quo, but I realize the winter is coming for me and my wife and I, and we're preparing for that transition. So in summary, here's the diagram that really shows you the importance of changing from that individual action that I was so focused on when I was a medical student, and to the we, which I've learned to incorporate in my everyday routine, and the opportunity to have a bigger impact for the community in which I work in. So I need to thank my wife, Sandra, who's been on this journey for ever. We dated in high school and broke up, got back together in college, and been together ever since on my interviews and the like. My son, Malcolm, and Morgan. Malcolm's actually a medical student here and did orthopedic residency here, and is now faculty at Duke. And my daughter, Morgan, and my family, my mentees. I have a set of frat brothers that I talk to routinely. St. Louis Children's research team. We did something that nobody thought we could do. On the Vanderbilt research team, the Ghana research team, and then families and children with sickle cell disease. Thank you very much.
Thank you. That was just extraordinary. We have well over 100 people on Zoom, so I'm going to try to moderate the Q&A. So Michael mentioned that I'm past president of APS. Michael is president-elect of APS. We are really looking forward to what's going to happen in the coming years. I will say that this year, applications for membership to APS doubled. So I think we're on to something, and I think every division chief knows now why we're so excited about the work that APS is doing. So, and you know, Michael's had a very busy 2 days, and so excited to hear about his meetings with the Office of Child Health Equity and with the House staff later. So we have two really important but quite different questions. The first one is from Eric Sibley, who says, you're an outstanding lecturer by a brilliant, dynamic academician. Eric is our past Associate Chair of Academic Affairs, and he's asking, what do you think is the best approach for institutions to identify and then recruit multiple UIM, particularly African-American faculty like yourself?
Thank you for that easy question, Eric. You know, clearly, if there was a solution, somebody would have implemented it. And so, honestly, I think that there's an ecosystem. We talked about it last night at the dinner table. The most brilliant minds in the world are on this campus. And it seems to me that there could be a better connection, a stronger connection to make sure that the undergraduate students who are of color, who decide to come to Stanford, get the level of mentorship and support so that they don't leave Stanford without the ambition that they came in with. And I think if you really pay attention to these brilliant students who come in and then in some way, shape, or form get discouraged from going into medicine or going into engineering or going into other quantitative sciences without really understanding that there's an ecosystem that exists that the Black students are typically locked out of. It's no different than when I was at Washington, I paid attention to how people became successful. And then when I came to Vanderbilt, I said, oh, they're not applying the same approach. So it was very easy to say, let's just apply the same approach that I've seen these labs, very successful labs, reproduce themselves, because there was no strategy to support those folks. So I would suggest the ecosystem that you've developed at Stanford and really making sure that those underrepresented minorities get a chance to have the same access as if they were the offspring of children who went to Stanford Medical School.
So speaking of the brilliant minds on campus, Eric Sibley and Carmen Powell conceived and launched in record time after the murder of George Floyd, a program called DRIVE, which is funded by the Maternal and Child Health Research Institute here at Stanford, where we bring UIM first generation and low income Stanford undergrads into Stanford Pediatrics lab. And the faculty embraced this in the middle of a pandemic, and we're incredibly proud of DRIVE. And now an amazing program called PIPS, where we had high school students do something very similar this summer. And the program not only included extraordinary mentorship and support for them, but Alison Guerin spearheaded efforts where she helped their families understand how to fill out college applications. So thank you. We agree that's a brilliant idea. Now it's something totally different. About why the adult haplo-HSCT experience less graft failure. Is there a difference in the health or robusticity of the marrow or stem cells of the adult recipient versus the PEDS recipient? Calvin's thought is that with less years of stress marrow in PEDS, the recipient marrow milieu is relatively stronger than that of the adult, and may explain why adult marrow failure has less graft failure.
Yes, so this is a name that probably only Bert Glader will know, Teresa Vietti. And so for our as a HEMONC fellow, we had to do biopsy. We had to review biopsies and aspirate routinely at 7 o'clock in the morning, and for a month. And we had a chance to look at the biopsies of adults and children with sickle cell disease when they were done in the 60s. And the adult bone marrow is basically barren. It's full of fat cells. And so when you look at a child with sickle cell, it's hypercellular. And so it's most likely just a matter of the fact that the adult bone marrow doesn't have the same residual stem cells and has less capacity for regeneration than the children with sickle cell.
All right, do we have any last minute questions from the people in the room? Oh, Bert, Dr. Glader, please. And you know what, we're gonna repeat the question so the people on Zoom can hear it.
was your slide about showing no progress in survival, 45 years, whatever the number was. Yet we've had hydroxyurea for 30, push that, tout that as being effective drug.
Want to repeat the question?
Yes, so the question is, we all are believers that hydroxyurea improves the lives of children and adults with sickle cell disease. And even in that study from UNC and Vanderbilt, there's 60% of the adults with hemoglobin SS were on hydroxyurea. Why don't we see an improved survival? Well, one is that we probably didn't follow them long enough. And so we have another cohort study where we have followed the patients for about 8 to 9 years, and we do see an improvement in survival when on hydroxyurea when compared to not being on hydroxyurea. So that's one. But more importantly, in that odds ratio, or the hazard ratio is maybe 2, statistically significant compared to patients without hydroxyurea. The biggest risk factor for death is the absence of insurance or /100% Medicaid for all the time they're being followed as adults. So when you divide the patients into 3 groups, always on private insurance, sometimes on private insurance or Medicaid, Medi-Cal, between 1 and 99% are always on Medicaid. So those are the 3 buckets. The group that was always on Medicaid when compared to the group with private insurance, the hazard ratio was 8. There's no biological factor, hydroxyurea, baseline hemoglobin, nothing predicted death more than being on Medicaid 100% of the time as an adult provider, as an adult patient.
I am really sorry because we have other commitments right on the hour, and so we're going to have to end early. It's very, very busy day. And I just wanted, the last thing I want to say is, you mentioned Melvin, the chair of pediatrics for Puerto Rico, and we're really delighted that he's in the queue to come give us grand rounds. I know there's a lot of people who want to talk to you. We'll have really great conversations over the course of the day. And thank you to everybody who joined us. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.